Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to the first episode of a brand new podcast from PrescQIPP called Talking Meds. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. I'm a hospital clinical pharmacist by background and used to work for many years at NICE and before that the National Prescribing Centre. But first, a little bit about PrescQIPP. We're funded by the NHS for the NHS and our aim is to improve medicines related care for patients. We do this by producing high quality evidence-based resources and training and by facilitating networks between NHS organisations and professionals. The majority of pharmacists and other healthcare professionals across the UK can access our resources by registering and logging onto our website www.prescribing.info. If you have any difficulty accessing the website, you can email us at help@prescribing.info and we'll aim to sort things out for you. Talking Meds will be available to listen to via your usual podcast system, and a new episode will come out every fortnight on the first and third Friday of each month. It will be an informal chat between me and a different guest each time, where we will discuss topical issues related to medicines optimization. So today I'm super excited to be joined by Magnus Hird. Magnus is a clinical pharmacist who I've had the pleasure of knowing for, 20 years now, Magnus. We worked together at the National Prescribing Centre, where Magnus is one of the first practice-based clinical pharmacists in primary care in England, and then very quickly did his independent prescribing qualification. And I've always been really, really impressed with Magnus's work. He has a portfolio career now as well, which I'm sure he'll tell you about in a minute. So we're going to talk to Magnus today about the day in the life of a practice-based primary care clinical pharmacist, but also we're going to talk about a couple of papers that I found really interesting. One, which is looking at the safety of non-steroidal anti-inflammatories, and another one looking at the safety of short-acting bronchodilators in asthma, both of which you might think, well, crikey, these aren't new stories, are they? And they're not. But there still seems to be safety issues with them. So it's something that we think is really, really important to talk about. So Magnus, do you want to just introduce yourself and just say a little bit about what you do on a daily basis?
Yeah, morning, Jonathan. Really nice to be here. And yeah, reflecting on over 20 years working together, it's a long, long time. So as you said, I work 2 days a week in a general practice in Blackpool. I've been employed by that practice for the entirety of the last 20 years. Working in the same clinical team, which is a real privilege to have the opportunity to develop lasting relationships with the clinicians and the patients there. I also do a day a week as a clinical lead for ambulance commissioning for the North West, so providing input around quality and safety, and another day a week for NHS England advising around urgent care to the regional team, alongside some other smaller portfolio jobs in advice, training, consultancy, and so on.
So, I mean, the thing that strikes me first of all is how on earth do you fit it all in? Because the other thing that people don't know as well, you also have a small holding farm as well, don't you, Magnus? I've always been astounded by how you manage all these different things. But I'll put it in the show notes. But if anyone's interested in Monk Hall Farm, you can follow Magnus on Instagram and Facebook, and it's absolutely fascinating stuff. But just in terms of the actual sort of like your day job as a pharmacist, as a clinical pharmacist, how do you fit it all in?
I guess it's a case of making time count, using those opportunities to, maybe check emails for one job when you're on a lunch break for another, and really juggling. There's a lot of finding the time around each other, which creates a bit of complexity. You have to be really aware of your diary, but stuff gets fitted in. It's not too bad.
So in terms of your role within the practice then, so you're part of the management team in the practice. You're not a partner though, are you? You're
not part of the management team.
Yeah, but you're part of the senior management team for that as well. So in terms of the patients that you see, and you say you work 2 days a week, that there must be, I would have thought, lots and lots of patients who you could potentially see. But how do you go about prioritizing those ones who are most likely to get benefit from your wisdom?
I mean, it's a real tension, isn't it? You're absolutely right. There are 16,500 patients in the practice. We have 8,000 people on repeat prescriptions, but I'm lucky to work in a fairly large team. So alongside the medics, the nurses, there's 4 of us as pharmacists and a pharmacy technician for our 16,500 patients. So we've really gone wholesale into clinical pharmacists in primary care because of the versatility and the skills that we can offer. Where I think we should be working is in the complex end of the spectrum. I'm perfectly happy to see somebody with a straightforward case of hypertension and nothing else wrong with them, but it's really probably a waste of my skill mix. So I tend to try and make sure I'm seeing the complex patients, so those with more challenging cardiovascular disease, so heart failure, AF, complex comorbidities, the serious end of renal impairment, and the chronic diseases that perhaps aren't part of the typical practice nursing portfolio. So who looks after osteoporosis, for example? Who looks after people with bowel disease? They're not typically in that portfolio, but they still need some support, and we can provide capacity gains for a practice by working in that domain.
And how does that overlap with the other clinicians in the practice then? I mean, you sort of mentioned it about the nursing, but what about the physicians, the medics in the practice? How does that work?
I think really well. It's evolved organically over time as my own skill set and competence has evolved, and as my colleagues have come on board and developed theirs as well. And our reception team have almost grown up with us, and they are used to where our skills lie, the sorts of patients we're happy seeing. We have a really good relationship with them, and they'll talk to us. They'll ring us and say, "Is this patient okay for you? Or does it need to see somebody else?" And by and large, there's very little that ends up in an appointment with me that I can't deal with. I guess that's the benefit of 20 years experience in a practice, is my scope of practice is very broad. But the targeted stuff where we're inviting people to come in, we make sure that we're targeting that at the complex end of the spectrum so that we're making the best use of our skill set.
Yeah, no, I think that's exactly it. I mean, I think I said before that I've done some work supporting the National Polypharmacy Programme with Claire Howard down in the Wessex HIN. And we've had about 1,000 people come through that now, and most of them, the struggle with the complexity. A lot of the pharmacists struggle with that sort of dealing with uncertainty, working in the grey rather than the black and white. And I think that's the bit that you've just talked about, that complexity. It's difficult to define it, but you know it when you see it, don't you?
Absolutely.
And the other thing that I'm really interested in is your work across sort of urgent care and your work with the ambulance service and 111 and the first response sort of team. One of the things, again, one of the themes that comes across in the polypharmacy action learning sets is that liaison between primary care, secondary care, urgent care, care of the elderly services, those sorts of things, and it's that communication that's really, really key, isn't it? So how has that worked for you in terms of your insight as a clinical pharmacist in primary care, helping 111 and the ambulance service and the urgent care response?
So my roles there are largely strategic and mostly focused around system design and quality and safety. So I chair a regional committee that looks at the quality and safety of ambulance service delivery. In terms of the sort of strategic redesign, we're looking at patient flows across urgent care, about things like access to records, about how we make best use of out-of-hospital pathways. And I think you're right, urgent care isn't the place to manage a complex comorbid patient. It's the wrong environment to be making long-term decisions. So sometimes you have to respond in a moment to a crisis or an exacerbation, but really we should be trying to head those off, deal with them earlier, have some good care plans in place. And then if somebody does have some kind of crisis, yes, we manage it at the moment, but we stream them back into their usual primary care teams to review that event, look if it changes future priorities and plans and so on.
Yeah, that makes lots of sense. I think one of the things that breaks down there potentially is that discharge communication type thing, but also there is a reluctance, I think, in primary care, if something's been started in secondary care, to review that. And it's really important what you just said. In urgent care or in secondary care, you're dealing with the situation now, almost trying to save the person's life in some ways, not managing their long-term condition. And that's the difference, I think, between primary and secondary care. So one of the things we talk about is giving primary care clinicians the confidence to review medicines in a way and actually think about, importantly, what matters to the person in the longer term, not just in that acute crisis situation. And I think that's really important, isn't it?
Yeah, absolutely. Fixing a fracture or semi-major bleeding or having primary PCI for a heart attack isn't about your thoughts and preferences over the next 20 years. It's about surviving the moment, isn't it? What do we do after the event around bone protection or around cardiovascular protection absolutely is about your values and preferences for the next 20 years.
Absolutely. Absolutely. I mean, I think that brings us nicely on to these two papers that we've brought to discuss today. So the first one, and we'll put this in the show notes so you've got the link to this, listeners. The first one is a paper that was in the BMJ this year. It's authored by various heroes of mine, actually, people like Rachel Elliott and Darren Ashcroft and Tony Avery, who's the national clinical lead for prescribing, and it was looking at the harms that are associated with the prescribing of non-steroidal anti-inflammatories in particular patient groups who you would think would be ones that you would try and avoid prescribing non-steroidals in. It's based on the PINCER data. So again, we'll put this in the show notes, but PINCER stands for the Pharmacist-led Information Technology Intervention for Reduction of Clinically Important Errors in Medicines Management. I'm just remembering that off the top of my head because it's something I was really interested in when it came out at the time. Claire Howard had lots to do with the rollout of PINCER. So PINCER is a sort of a pharmacist-led IT intervention where you identify patients who are at risk of potentially hazardous prescribing. And then the second part of this was that there was trained a lot of pharmacists to go out and do academic detailing, academic educational outreach to prescribers to talk to them about the patients who were at potential high risk. Anyway, this paper used some of the PINCER data, which was identifying the first part of that, identifying those who were at high risk of avoidable harm. So what they did was they looked at patients who were prescribed a non-steroidal either and had one of these 5 high risk factors. So one, they were prescribed an NSAID without co-prescribing of gastroprotection, and they were 65 years or older. They were prescribed gastroprotection to people. They were prescribed a non-steroidal without gastroprotection and people with a history of peptic ulceration. They were prescribed either a warfarin or a DOAC, a directly acting oral anticoagulant, or they were prescribed a non-steroidal to patients with heart failure or chronic kidney disease. So again, those things that you would think you'd be really worried about prescribing a non-steroidal in those patients. And surely there can't be that many people who get prescribed these non-steroidals in this patient group. But what they found from the PINCER data was there was actually quite a lot of people who were found who were prescribed non-steroidals in these circumstances. And they modelled this across the whole of England. And they reckoned that if there's about 60 million people who are registered with a GP practice, around 110,000 of them would have been in this category. And then they quantified that in terms of the quality adjusted life years that would cost in terms of harm to the person, and then put a monetary figure onto that. So this is Rachel Elliott's work, where she's really good as a health pharmacist, health economist, to put that into monetary terms. And it's fascinating how much money was associated with this, and you shouldn't think about this just in monetary terms, but it's about £2.5 million a year just for this intervention. Well, what did you think of this, Magnus, when you saw it?
I think similar thoughts to you, Jonathan. These are 5 groups where you think you wouldn't want to go near them with an NSAID without either the PPI or at all. Yet there are tens of thousands of patients. There were over 20,000 just anticoagulant users being prescribed an NSAID. Something you just think, gosh, someone's got to be pretty brave to do that. But 20,000 times. So although this is maybe old news, it's not news we've all taken on board and maybe worth another look.
Indeed.
Going back to the point you made earlier around prioritisation, so looking at the sort of 5 discrete groups, there were a couple that stood out. So you concentrated the opportunity for health gain in terms of qualities to improve and finances to save, predominantly in the anticoagulant users and the patients with more significant renal impairment, so your CKD stage 3B and worse group. The other groups there were gains to be had, but they were much smaller.
So again, as you said, it's about prioritisation. It's about making sure that you're targeting the people, but importantly, to have a conversation with people about what matters to them. Yeah. Do you remember back in National Prescribing Centre days, Magnus? I came up with this thing which was called the 3 steps to NSAID heaven. And this is all down. My mum was a massive fan of the song 3 Steps to Heaven. And I came up with this. The 3 steps to NSAID heaven were: only use one if you really, really have to. So try other things first, such as exercise and physiotherapy and other analgesia, perhaps. And then if you do have to use one of the safer ones, such as ibuprofen or loads of ibuprofen or naproxen, in the lowest dose that possible for the shortest amount of time. And then the third one was use gastroprotection in those who are at risk of GI bleed. So those, if people had been following those 3 steps, then we probably wouldn't have seen as much of this as we do. However, there is another side to this as well, in that NSAIDs are a really, really effective analgesic, anti-inflammatory in some people, aren't they? And again, it's about that question that you have to ask whenever you're doing any standardized medication review is, what is it that really matters to you? So if you've got knee pain and it's really, really bothering you, and you've tried other things, it might be that an NSAID, even though you have got risk factors, is worthwhile to you because it's really, really important that you get mobile again. I've got again, as a pharmacist, I'm really, really averse to taking medicines. And I've had patellar tendonitis in my knee for about 3 years now, and I just put up with it. And I went to physio, and the physio said to me, "Do you take any ibuprofen?" And I went, "No, I don't, because I'm a pharmacist and I don't trust them," sort of thing. Anyway, I ended up having toothache, which was keeping me up at night, and I took some ibuprofen. So it must have been bad for me to take some ibuprofen. And about 2 days later, I realized that the pain in my knee had gone, and I could go and walk for much longer without it hurting me. And I'd just forgotten about the need that would give me to then enable me to do other things, such as take exercise and do the things that I like to do. So you can see why non-steroidals do have a place in some people, but we just need to be careful with them as well, don't we?
And so we've got to be careful, but we have to consider the pros and the cons of both the NSAID and the PPI that goes with it potentially, and have those conversations with patients about what really matters to them.
Yeah.
So, taking your example, we've actually conferred a huge health benefit, whether with a little bit of ibuprofen. Not only has it relieved some pain, but it's also enabled better function. That better function will help your cardiovascular fitness and might improve your cardiovascular health long term. It might keep weight under control, which lowers the risk of some cancers. So it can become very, very complex very quickly to try and work out pros and cons long term. But even working at a relatively simple level, trying to give people rough estimates of what's the risk of this so they can compare and contrast against the benefit they perceive and make a decision about what matters most for them. That's a critical skill.
Yeah, absolutely. And this is why doing medication review by checklists or by just using computers doesn't work as well as having a human being listening to the person and working out what it is that's most important to them. Because as you say, you follow the you just follow the rule book, if you like, and you think, oh, you shouldn't be prescribing non-steroidals in this cohort of patients or this particular individual. But you need to take into account the other things that are going on here as well, as you beautifully articulated. So that's that paper. The other paper that I thought was really interesting was in the British Journal of General Practice in August, and it was about the management of asthma, and in particular looking at the prescribing of short-acting beta agonists or SABAs, so things like salbutamol, in people with asthma, and again, one of the markers for poor quality care in asthma is how many SABAs are being prescribed to people. And if you look at your registers, and there was I think in 22-23, one of the NHS England incentive scheme for primary care networks was looking at those people who are prescribed 6 or more SABAs within a year. They would be the flag for you to look at. Oh, you might need to do an asthma review here. And what these people found, this is Toby Capstick and Mark Levy and Thomas Antalfi. What they found was, again, lots and lots of SABAs being prescribed, and again, this is something that you wouldn't necessarily expect to see, because the guidance from GINA and the new draft guidance from NICE says don't prescribe a SABA on its own. You should be prescribing an inhaled corticosteroid in combination with a bronchodilator, not on their own. What do you make of this, Magnus?
I think the headline that stood out to me was that the high SABA users not only had more than 3 times the rate of admissions, but more than double the healthcare costs. It costs more money to do a worse job.
Yeah.
This is an absolute no-brainer to work on. You know, when I first started in pharmacy over 25 years ago, I remember some CPD at the time that said 1,000 people a year die of asthma and most of it's preventable.
Yeah.
And if you look at every single one of the national reviews of asthma deaths, the Asthma UK annual surveys and so on, we haven't moved on. It's still over 1,000 people a year die of asthma, and still most of it's preventable. Now, there's a variety of causes, and I really empathise with the challenges involved in this. We serve a really deprived population, and it's incredibly difficult to sometimes engage people in their health, to address the lifestyle behaviours that are behind this, to increase health expectations so that people understand it's not normal to just be constantly out of breath with asthma or be coughing and wheezing. You know, it's readily achievable to get good control and really improve quality of life. It's also a challenge sometimes, I think, to unpick what's asthma and what's other stuff causing breathlessness or wheeze. So smoking, being overweight, being unfit, occupational exposures, household exposures. You know, we've got a lot of dampness and mold in our housing stock in Blackpool. So it can sometimes be tricky to unpick that, and that's where the real life population differs from the clinical trial population. But we absolutely need to do some work on this. The other thing that I think stood out to me was the evolution of the risk threshold over time. We've known for a really, really long time to focus on patients using a SABA device a month. Then we have the IAF indicator saying we'll look at people using 1 every 2 months, the 6 a year. This paper is saying actually 3 canisters a year is associated with increased healthcare utilisation and increased risk of death. The threshold has gone down progressively as we've understood this better, and I think it fundamentally has to change how we look at managing asthma from day one.
Yeah, no, definitely, I completely agree with that. And the thing that also strikes me here is that it's the need for asthma treatment plans. So, have you got an asthma treatment plan? Would be the question that I'd ask patients with asthma. And do you know how to follow it? And do you know what it means? Do you know what to do if you have an exacerbation or whatever? And so that's for patients. But the thing for practices is, do you have a plan to escalate patients quickly if they get in touch with you and say, actually, I'm having exacerbations of my asthma more often than I used to? I don't think it's good enough to wait 2 weeks for an appointment for this, is it, Magnus? I know it's difficult to get access to primary care these days, but
it can be a real challenge. You know, the demands are extreme at the moment. But this is a population, we know the hallmarks of asthma are variability. So people can escalate really quickly, and we need to be in a position to be able to respond to them. Another critical group that's worth thinking about are those that have just had an exacerbation. So they've had an emergency attendance or a hospitalisation. And it's critical to follow those people up soon after, because that steroid course will only last 5 days or so. And as soon as that finishes, unless they've taken real steps to change their asthma control and their approach to asthma management, they're going to go back around the loop again.
Yeah.
That steroid will start to wear off, the inflammation will surge back again, the underlying disease wasn't controlled, we're going to be back at square one. So that's a real opportunity to engage and reinforce the preventative treatments.
Brilliant. And again, if people want to read the draft NICE guideline, it's up there. It's saying all the things that Magnus has just said about asthma plans and the need to do something about this. I think the final guidance is due out in I think November time. It's been put back to then, and this is NICE and SIGN together producing asthma guidance. Which is really good, because what you don't want is a disconnect between NICE and SIGN, which we've had in the past. So that's really good. Okay, thanks for that, Magnus. I think just to finish off, then I think it would be really useful just to give listeners sort of a little bit of an insight into your wisdom, really, and what you've learned over the years about being a clinical pharmacist. What would you say the 3 things for people to get good at would be if they're going to be a clinical pharmacist within primary care?
I think I must be definitely getting old if I'm just have wisdom. It always brings to mind like a Gandalf type picture. 3 things. I guess the first one is that multidisciplinary team working. Healthcare is far too complex for one discipline. Nobody can know it all. Nobody can do it all. So you must work as part of a team. You must play to your skills, but also play to others' skills. So use your colleagues, be used by them, have great networks to get the right people engaged in patient care and support what you do. The second thing is consultation skills. It's all about the conversations with patients. We need to be absolutely phenomenal at building rapport, at helping patients explain what matters to them, about drawing out of them their understanding of treatments, of options, of risks, helping them reach decisions that they're happy with about their long-term care, whether that's starting something, stopping something, whatever. And then the last thing, I think is really about living with uncertainty, being able to manage risk, working out how to prioritise, use your skills best. But we have to be working in the complex grey. That's where our skill set lies.
Again, it's probably no surprise to you that I could not agree more with that. I mean, I've spent the last 20 years trying to improve people's consultation skills and understanding of evidence-based medicine and how people make decisions, and that decision hygiene sort of stuff that is really, really important. And living with that uncertainty is really important. I think as pharmacists, sometimes we're taught as a science-based degree that you take a drug, you take a medicine, it has these effects on the receptors in your body, and it produces this effect, and it doesn't. It doesn't. And I think it takes pharmacists a while to get used to that uncertainty, that sort of things reduce risk by a little bit. They don't obliterate risk. And that team and skill mix thing, I think that's really important as well. We're seeing that more and more, aren't we, with the roles that are being done by different pharmacists in different parts of the health system and care system, and skill mix is really, really important there. So thank you so much, Magnus. That's been absolutely fascinating. Thanks for listening, guys. We'll be back soon with another episode of Talking Meds. So cheers.
Thanks for having me on. It's been great.